Neurology quiz number 58. What are the clinical features and management of occipital neuralgia? Occipital neuralgia is characterized by unilateral or bilateral paroxysmal shooting or stabbing pain in the distribution of the greater, lesser, or third occipital nerves. The paroxysms last from a few seconds to a few minutes and are severe in intensity. It is more commonly unilateral. The greater occipital nerve is involved in 90% of the cases. Pressure, palpation, or percussion over the occipital nerves may reveal local tenderness, and these can also trigger pain, exacerbate the background discomfort, or elicit paresthesias in the distribution of the nerve. In the proper clinical setting, the diagnosis is confirmed when pain is transiently relieved by an occipital nerve block. Pain may sometimes reach the frontoorbital area through trigeminal-cervical interneuron connections within the trigeminal spinal nucleus. These are the ICHD-3 criteria for occipital neuralgia, incorporating the clinical features described earlier. The greater occipital nerve derives from the C2 dorsal ramus, emerges at the posterior skull base, and ascends to the vertex. The lesser occipital nerve originates from C2-C3 in the cervical plexus and wraps around the sternocleidomastoid to innervate the lateral scalp, including the top of the external ear. The third occipital nerve derives from C3 dorsal ramus and supplies the lower occipital scalp and upper medial neck. Here, figure A shows the greater, lesser, and third occipital nerves, while figure B shows the cutaneous innervation of the greater, lesser, and third occipital nerves. Lesions such as occipital nerve schwannomas and cervical root stretching by Arnold-Chiari malformation can also cause pain in the occipital nerve distribution. Rarely, the condition may be secondary to lesions in the upper cervical cord, such as demyelinating lesions and cavernous malformations. MRI brain and cervical spine should be considered to rule out underlying lesions. Patients with migraine may sometimes be mistaken for occipital neuralgia, as they can have tenderness over the posterior skull base and can respond to occipital nerve blocks. Treatment includes analgesics such as NSAIDs, anti-epileptic drugs such as gabapentin, pregabalin, and carbamazepine, antidepressants including tricyclic antidepressants and SNRIs. For severe exacerbations, nerve blocks can be performed by injections or local anesthetics combined with a corticosteroid. This can provide relief for a few weeks to a few months. Patients not responding to medical treatment or repeated nerve blocks may benefit from radiofrequency ablation, botulinum toxin injections, chemical neurolysis, or occipital nerve stimulation. Here the figure on the left shows targets for occipital nerve block. Target A is for greater occipital nerve, which is 2 centimeters below and 2 centimeters lateral to the external occipital protuberance. Target B is for the lesser occipital nerve, which is approximately 2.5 centimeters lateral from target A. The figure on the right shows an occipital nerve stimulator. The stimulator is inserted at the base of the skull where the occipital nerves originate. The device has leads linked to a pulse generator which is implanted under the clavicle, gluteal, or abdominal areas. An occipital nerve stimulator is also used to treat resistant cases of migraine and cluster headache.